Hello, everyone. Thank you for joining us today at this Baker Institute webinar, How Can the COVID-19 Experience Help the U.S. Improve Health, Not Just Healthcare? My name is Vivian Ho. I'm a health economist at the Baker Institute in the Center for Health and Biosciences. We have a 1-hour program for you today, and we have two guests, which I'll introduce in a minute. We're delighted that we have the Honorable Lynette Diley joining us, as well as Elena Marks. The way we'll run the program today is Ms. Diley will give an introduction to the work of an organization you may not have heard of, the Episcopal Health Foundation, but you're going to find it plays a key role in today's subject matter. Then Ms. Marks will address today's main topic, and Ms. Marks and Ms. Diley will then discuss how the Episcopal Health Foundation and organizations like it can help in the pandemic. And that's going to leave us ample time for question and answers from viewers. So let me just give a brief introduction for our two speakers. Lynette Diley is the chair of the program committee for the Baker Institute Board of Advisors. She's also the executive chair of the Episcopal Health Foundation. She is a former U.S. ambassador to the World Trade Organization, as well as a former deputy U.S. trade representative. Elena Marks is a non-resident fellow in health policy at the Baker Institute, and she's also president and chief executive officer of the Episcopal Health Foundation. So with that, I'm going to hand things over to Lynette.
Thanks, Vivian, and good afternoon to everyone. In 2013, when the assets of the St. Luke's Health System were transferred to the Catholic Health Initiatives, the Diocese of Texas created a new foundation, the Episcopal Health Foundation. And we spent much of 2013 focused just in terms of the building blocks of that foundation. We needed to form a board. We need to hire a president, as you're going to hear from Elena, who's been our president from those beginning days. And we needed to build a staff, a team that could help us with our work. We had a group, the Episcopal Health Charities, that we folded into this organization. So we had a starting block from which to begin and some experience in that process. As you can imagine, we began to focus on a strategy of what were we going to do with these assets and how best might we use those, putting together a strategic plan. And as we did that, we focused very much in terms of the Diocese of Texas, which is a little bit of a misnomer. It's not the entire state, but it's a big bulk of the state in terms of the population. It includes Houston to Austin, up to Temple and Waco, over to Tyler and all of East Texas down to Beaumont. So a good bit of the state, both in terms of population, but also a good mix of very urban environments as well as rural, each of which have different healthcare needs. But we decided we wanted to focus on a broad base of how we could improve the health and the well-being of the millions who lived within this territory, within those counties. As we went about that process, we knew we would do it in a variety of different ways, from making grants to organizations that serve that population, by doing research on what were the critical health initiatives that we might need to be using, by focusing on the communities and how those communities might be better organized to deal with their health challenges, and also with our congregations, because we had more than 150 congregations within the diocese, so there was a lot of volunteer labor and a lot of volunteer interest within those congregations also, and we wanted to harness that. We also decided early on that we wanted our work to be transformational, that we simply didn't want to just be writing checks, as helpful as those might be to people, but we wanted to really change and improve the overall health in our communities. And we decided as we did that, we needed to approach our grant making particularly by looking at things from an upstream perspective. And that may be a term that you're not as accustomed to for health in the health context, but for us it meant it was a shorthand for saying, how could we identify or how could we better prevent the causes of illness and the causes of injuries? And so felt if we could focus on that rather than simply dealing with the health care system itself, and Elena will talk a great deal in terms of how we've gone about that. As we began then to analyze what that meant, what the root causes really were of the issues that we were seeing in health, that led us to focusing in terms of what outcomes we'd like to see. And the first was focusing in terms of health systems themselves and what we might see as a health system reform. It's not certainly we provide great health care, but our overall components of what leads to good health does not necessarily work as well as it should, and it certainly is not particularly interconnected. And so, for example, in one of our communities, as we've focused in terms of this work in recent time, we brought all the major health providers in that community together. And it was the first time they'd ever been together to talk about what either might be some inefficiencies or what were some gaps in terms of their service. And it certainly has made a great deal of difference in that area. We also knew that the prime way we were going to reach out, particularly to the underserved in our communities, the major focus of our issues, were by focusing on terms of community clinics. We had good networks of community clinics in many of our communities, but we knew that they were really focused primarily in terms of dealing specifically with the people who walked into the clinics rather than having the opportunity at the time to look at the broader community issues. And so we've made a number of grants to our community partners in the clinics, helping them to reach out in their community and some other efforts. We also knew we wanted to help focus in terms of building communities, and that's where the community engagement and the congregational engagement has particularly been important to us as we've reached out to try and build those connections within the variety of communities in the diocese. And finally, we had a very specific effort that we focused on in terms of early childhood, and particularly in terms of the brain development in very young children from birth to 3. There's a great deal of research now suggesting that those issues are so critical in the future development of our children. And so we've been a pioneer really in some of that effort, and we're quite pleased in terms of the results that we're having there. So that's a quick snapshot of what we're about within the Health Foundation. And now I'll pass it off to Elena to talk more specifically of our topic for today.
Thanks, Lynette. Let me get my system working here. Okay. These charts must look familiar to everybody by now. They're from Johns Hopkins University's tracking system. In blue, you can see the number of cases. Red, you see the number of deaths from COVID. This is data that came in as recently as yesterday. And in the midst of this deadly crisis, we're all focused on life-saving medical interventions. We're making sure that our healthcare system is up and running, that it can take care of us, that we have enough ICU beds, that we have enough ventilators. It's really important to save the lives of those who are infected. And we're rightly super focused on healthcare right now. But when we get out of this, and we will, and when we're putting the pieces back together, we actually have the opportunity to improve our system by moving upstream. Before COVID, we were all talking about health reform, health system reform. Mostly, though, we were talking about healthcare, and a lot of that conversation was about high prices, sometimes just about pharmaceuticals. So what I'd like to do today is walk you through a partial critique of the current system from a different perspective and use the COVID-19 pandemic as a vehicle for highlighting some of the weaknesses in the current system. And then I'm going to propose some ideas for a post-COVID system. So I want to make 3 points. First, despite our obsession with healthcare in this country, it's actually social, economic, and behavioral factors that are much more influential and more determinative of our health status and our health outcomes. Let me show you why. So this slide is a distillation of decades worth of data by many, many researchers, and it shows you what factors actually contribute to quality of life and quantity of life. And so if you want to improve the health of people, then you have to know what are the factors that drive their health outcomes. And so as you can see on this one, social and economic factors are responsible for 40% of health outcomes. Health behaviors, tobacco use, diet, exercise, substance use, that accounts for 30%. The physical environment, is there pollution? Is there good housing? Transportation accounts for 10%. Only 20% is on account of medical care. There are actually some data sets that will show that that's only 10%. But my point is that of all of the factors that determine whether or not a person or a population is healthy, medical care is actually a pretty small piece. And so if you know what the drivers of health are, you would think that we'd align resources accordingly. But we don't. This slide shows you the drivers of health from the previous slide, and next to it is a breakdown of the $3.6 trillion in annual national health expenditures of our country. These are public dollars, private dollars, insurance dollars, individual dollars, government dollars, your dollars, my dollars. And as you can see, medical care, which is only 20% of the drivers, is using up almost all of, more than 97% of the entire national health expenditure budget. Other countries make bigger investments in social services and smaller investments in healthcare. This chart shows you data for 25 different OECD countries. The light green bottom part of each bar is the percentage of that country's GDP that it spends on health, on social services. The top part of the bar, the blue part, shows you the percentage of GDP that each of those countries spends on healthcare. And when you look at this chart, what you see is that the US spends way more than anybody on healthcare and less than almost all on social service spending. Our total spending is not out of line. It's a little on the high side, but it's not the highest. But our ratio of spending, where we put our dollars, is different. And here's how it looks against some health outcomes. Our life expectancy trails behind all of these countries. Our obesity rate is higher than that in all of these countries. And our infant mortality rate, can we keep babies alive until their first birthday, is higher than these other countries. So I want to look now at how the overinvestment in healthcare and the underinvestment in social services relates to COVID. So we already know a month into this, 2 months into this, who is being most severely affected by COVID-19. And it's the non-medical factors that have exacerbated the effects on those people. First, chronic conditions. We know that if you have underlying chronic conditions like diabetes, that you are increased risk of becoming severely ill or dying if you contract the virus. And yet we know that conditions like diabetes are largely preventable, and not through healthcare. They're preventable through diet and exercise. Now, there's some diabetics who make poor choices that lead to diabetes, but there are many people who live in circumstances where having a healthy diet and getting exercise are just not feasible. Think about housing. How do you stay home and work safe if you're homeless? Or if you have a family living in a tiny apartment? What if your apartment is full of mold and just being there makes you sick? Think about employment and income. Some people can't stay home. They only get paid if they go to work. They may not get any kind of sick leave. And do they really have a stay-at-home, work-safe option? And if they do come to work when they're sick, who else is exposed? And think about food security. We've seen the gut-wrenching pictures of long lines at food pantries. And at the outset of this pandemic, people with money and cars were hoarding groceries and other supplies, and that was leaving low-income shoppers with fewer options. In fact, there's data that shows that even WIC-approved options, the kinds of food that families can buy with subsidies, were being picked over, and there wasn't enough left for the people for whom it was designed. Or think about living in a food desert and relying on public transportation to even get to a grocery store. Your options are increasingly limited in the world of COVID. The CDC data shows who's being affected by COVID. We already know that most of the people who are hospitalized with COVID already had a pre-existing condition, and many of those pre-existing conditions were caused by or accelerated by the conditions in which people were living. We also know that African Americans have been disproportionately adversely affected. They're sicker and they're dying at higher rates than other populations. The inequities in our system grow even more so during disasters. We saw this during Hurricane Harvey, and not surprisingly, we're seeing it in COVID. It's time to deal with it. In addition to the impact of lack of investment in social and economic factors, there's another weakness in our current system, and that's the divestment in the public health infrastructure. Pandemics are by definition public health problems. When public health is working well, it's actually invisible. Most people don't even know that public health is a field apart from healthcare. The reason we don't have TB running rampant in the general population is because of public health. It's the public health workforce that watches for patterns of disease, that plans for prevention and for containment, and that promotes testing and contact tracing to stop the spread of infectious diseases. But here's how we've attended to it. At the national level, our CDC funding has been relatively flat since 2011, and that's despite a 5% population growth over this same period of time. And that's especially true for programs that focus on the social determinants of health, such as the chronic disease prevention programs. Also, our public health emergency preparedness dollars are woefully underspent, underallocated. Similar divestments are occurring at this local level as well. This is data from Houston and Harris County. The green line is the City of Houston's health department per capita spending from 2009 to 18. And the orange line is the same for the Harris County Public Health Department. Yes, we have 2 public health departments in our area, and that's a conversation for another day. But over those periods of time, the per capita spending has actually decreased. And that's at the same time that population in Houston and Harris County has grown by double digits. Across the country, the local public health workforce has lost 55,000 workers since 2018. In addition to the divestment in public health and insufficient investment in social determinants of health, there's another problem with the current system. And it's about healthcare. Healthcare is important. It's important in COVID. It was important before, and it will be important after. And while we spend more on healthcare than any other country on the planet, we still lack a national system that provides for all residents to access affordable healthcare, including preventive care. The first problem with access and affordability relates to health insurance. Now, for better or worse, in the US, health insurance really is our means of access. And yet, before COVID, there were still 30 million people living in the US who were uninsured. And almost 5 million of them live in Texas. In Texas, we've missed a real opportunity to cover about 1 million of our 5 million uninsured by rejecting a Medicaid expansion. 37 other states took this opportunity, but Texas has refused to expand Medicaid. And as a result, we have the highest number and the largest percentage of uninsured people in the country. And as people lose their jobs, the number of uninsured is growing. Ask any hospital executive about the burden of caring for people who are uninsured, who often show up in the emergency room and often late in the course of disease. The uninsured face significant barriers to care. The columns on the left show you some survey information from Kaiser Family Foundation about the experiences that different groups of people have with the healthcare system. And as you can see, the experience of the uninsured is wildly different from those with public or private insurance coverage. They don't have a usual source of care. They don't go to the doctor as often, and they postpone seeking care at much higher rates than others. 12% of the high-risk people in America who are at highest risk for COVID and COVID complications are 5.1 million of them are uninsured. What happens when they get sick? And finally, what about affordability? We're paying by the piece for services without regard to outcome. Providers do what they get paid to do. We all do. And the current system is structured in a way that incents the provision of services, often piecemeal, in volumes, because that's how providers get paid. There are lots of cost problems in the healthcare system, but the way we pay for healthcare, this is a really big one. So enough criticism. Let me talk about some solutions. So a silver lining to the COVID crisis may be the opportunity to build a new system. And I'd like to share some thoughts on how we can address the problems I pointed out as we imagine a new system. So what's it going to take? First of all, we're going to have to change our minds, our perceptions about health and healthcare in this country. We have a uniquely American cultural bias toward believing that healthcare and health are the same thing. In fact, we think that high-tech, expensive healthcare is health. Our conversations about health in the US are almost always about healthcare. The conversation is politics about healthcare. Do we want a single payer system? Do we want Medicare for all, a public option? It's all about healthcare. But now we see, in the case of Corona, the limits of thinking of healthcare as the primary mechanism for promoting a healthy population. And second, we're going to have to change our financial investments. We're going to have to spend more money on the unsexy, often invisible field of public health. We're going to have to acknowledge the benefits of investing in health promoting systems like food and housing. And we're going to have to acknowledge the limitations of investing more and more dollars in healthcare. This will be hard. We've spent 100 years building a system based on hospitals, intensive medical procedures, and ever more expensive drugs. And yet many of our biggest health challenges are preventable and sometimes solvable by other kinds of investments. Today is an opportunity to retool our system so those in the industry are paid for and actually incented to deliver health outcomes, not just medical services. Here's what that might look like. So first, we need to acknowledge that the health system goes all the way from community health to post-acute care. It's not just a healthcare system. We have $3.6 trillion to address this system, and we're putting almost all of it in one end of the system. So you can think of this as an upstream, downstream conversation, or you can think about it as a continuum that goes from beginning with health promoting communities that enable people to live healthy lives, moves toward healthcare centered around primary care, and then all the way through to post-acute care. So how would we get there? First of all, for some low-hanging fruit, we've got to rebalance the $3.6 trillion in national health expenditures. You saw earlier that 97% of that goes to healthcare, less than 3% of that goes to public health. Public health is much less expensive than healthcare, and we still underinvest in it. It's estimated that $1 billion a year is needed to update the nation's public health infrastructure. And the budget was $50 million. There's another $500 million in the wake of COVID, and that's really good. But these investments need to be made annually, continuously, not just in the middle of a disaster. It's too late. We also need to accelerate payment reform. We've been moving very slowly in this country to move from volume to value. We are still paying for healthcare by the piece. And even though we've said we have a value-based system, the value incentives are really at the margins, where the incentives for going above and beyond are relatively small and the penalties for not delivering value are equally small. And that incents churning. It doesn't incent value. Let me give you a simple example that I use over and over again. Our healthcare system, our health insurance will pay for someone with asthma to get all the medications they need and to go to the doctor, go to the hospital, go to the emergency room as many times as they need to. But even when we know that their asthma attacks are caused by mold in their apartment, we won't spend less than the cost of one emergency room visit to fix that. We're investing in pieces of healthcare even when they don't deliver value in terms of health. And about the healthcare system, critically important, always will be. We've got to rebalance the way we think about it. And we have to talk about primary care as being the central piece of the healthcare system. Primary care providers have the hardest job and they're paid among the least among doctors. We need to pay them to manage people's health, not pay them to churn visits. We need to have them activate their role as the conduit between the person's life out in the community, where the social determinants play a big part in determining someone's health, and the healthcare delivery system. They should be the key, not hospitals, to a new healthcare delivery system. And finally, we've got to ensure that there is actually access to affordable care, and that begins with insurance coverage. We have to have a plan that covers everybody. It doesn't matter if it's public or private. It's just that it has to include everyone. The examples people bring you from other countries, some are fully private, some are fully public, some are hybrid. What the high functioning systems have in common that we lack is a universal comprehensive system where there's a place for everyone. And in Texas, of course, we've exacerbated what's even available to us by refusing a Medicaid expansion offered by the federal government. And that's why we continue to have the dubious distinction of the highest rate of uninsured and the largest number of uninsured people in the country. If we can do it for COVID, then there's some other things we can keep doing when we move forward. Disasters often create a different set of rules where we start doing things differently. And we say we're going to do it now for a little while because we're in a disaster and we need to change the rules. One example of that is the accelerated use of telehealth platforms. There's been a lot of resistance in various parts of the industry to using telehealth and a lot of concern that payments wouldn't keep up. What we are seeing in the age of COVID is that many patients can receive the services they need through a quick telehealth intervention with their provider. And we can keep doing that after COVID is over. There is no reason we have to continue to have a system that is centered around patients coming into, for example, the Texas Medical Center, finding parking, waiting their turn, and then seeing a doctor, if that same service can be delivered in a way that is much more user-friendly and in the long run, less expensive. We've also seen some loosening in the restrictions on provider licensure and accelerating everyone's practicing at the top of their scope. We have provider supply issues in this country, in part because the people who are in that business control, through licensure and medical schools, the supply of new physicians. And the fewer physicians there are, the higher the dollars are that they can command. We need to loosen some of that up. What we've done in COVID is allow practitioners to move across state lines. We have also increased reliance on mid-level practitioners. nurse practitioners, and physician assistants. We often see that their scopes of practice are more limited than they need to be. We have examples in the state and from around the country that when mid-levels are allowed to practice at the height of their license, we can actually deliver more services more cost effectively. And finally, if this has taught us anything, I hope it's teaching us the value of vaccines, and that the conversation we've been having about vaccines being a matter of either poor science or causing autism or not important need to just go away. These are three things that have been heightened in this crisis. Let's build them into a system going forward. So before we open it up for questions, I'm going to pivot back to Lynette and invite her on and ask her to give you a little bit of information about how the Episcopal Health Foundation is responding to COVID.
Thanks, Elena. Like many of you, we began the year with a plan for what we were going to try and get accomplished in 2020. And of course, like the rest of you, that's become totally upended with the crisis we're faced with now. So very quickly, Elaine and I and our rest of our board members began to talk in terms of what we might do to better respond to this crisis, because we knew this wasn't just a momentary issue. It was going to have lasting impact on us, and we needed to see what we could do to respond accordingly. So we began those conversations with our bishop and with the board to then decide what best we might do. And out of that decided we needed to focus on our existing partners. We had some 94 grantees that we've been working with in our recent years. And we knew a number of those were going to be either directly involved in dealing with the crisis or certainly impacted it. And those organizations frequently were those that were serving those disproportionately vulnerable populations in our midst. So those were going to be the beneficiaries of our action. We had a board meeting this past week to approve what we were going to do. And we said we would spend something over $10 million in terms of grant assistance or make that available to organizations that needed some extra help in this process. We'd already been talking about what we might do in terms of what's called impact investing, where we might actually be investing in our organizations, because sometimes that's more helpful for them even than a grant. And we decided, and this means it would be more suitable to do that in terms of loans, that there might be organizations out there that for either a short or midterm loan might be helpful for them in navigating these uncharted waters. We also very quickly decided we needed to do some technical assistance or offer that to our grantees, even originally just in terms of how they might access some of the government funds, because not everybody had the technical background to understand that access. And if they couldn't make the applications, they certainly weren't going to be able to get the grants. So offer that to a number of our grantees. And then finally, in terms of research, we're looking in terms of areas we might be able, through our research efforts, shed some particular light in terms of both what the issues are and how best to move forward. So that's been our immediate response from the Health Foundation to the crisis. With that, Vivian, I think that kind of wraps up our original discussion, and I think perhaps you have some Q&A that you'd like for us to respond to.
Yes, thanks. I've got some questions. Before we move to that, are you able to give one or two examples of some of the things that you funded related to COVID-19 yet, or some of the ideas that some of the grantees are proposing to you that you think are interesting?
Well, actually, we opened up the grant portal on Tuesday. It was fairly full by Tuesday evening. What we're really looking at is how we can help the business continuity plans of these frontline organizations. Many of them, are losing staff. They're losing patients if they're seeing patients. There are just a lot of financial difficulties that they're facing, like all other businesses in the country. And so we want to make sure that when this ends, because it will end, that they are as best positioned as they can be to go back to work. In addition to just business continuity, several of them have increased their use of and investment in telehealth, which is a good thing for the long term. And so we expect to see some requests for funding around that as well.
Thank you. So the first question I've got for you is, does income being a factor affecting health, you said it affects 40% of health at the start of your talk. Does this also relate directly to the ability to procure medical care too?
Absolutely. I mean, income and insurance status are linked. Insurance status is linked to access to health care. If you are of low income, if you're of too low of income in Texas, you simply can't afford insurance because we didn't expand Medicaid, and what's available, even in the Affordable Care Act marketplace, is unaffordable for someone up to 100% of the federal poverty level. Some of those people have opportunities through their employers, but many of them don't. And that's why we have 1 million people who are simply locked out of the system. Even if you're uninsured and you are wealthy, you can still pay for care.
Thank you. The next one is maybe more of a comment than a question, but I'd like to present it to you. This particular viewer said, the solution is all about primary, secondary, and tertiary prevention, focusing on healthy habits and a clean, supportive environment. See Northern Europe. So very much in agreement with what you're saying.
Exactly. And our country does not do as good a job as some other countries in providing, frankly, just family-friendly policies that allow ordinary people to live a healthy, safe life so that they avoid disease in the first place.
So this viewer is concerned about value-based payment systems. He says a value-based payment system is really a euphemism for rationing of services. What mechanisms can be put in place to prevent withholding of care or services?
Well, that's a great question. I'm going to take a shot at it. And Vivian, I think you've got something to say on this topic too. So first of all, I would say we ration services today all the time, and we ration it based on wealth. And I find that troubling. If you have a value-based system where the value is a health outcome and you have appropriate metrics to check on those outcomes, then you shouldn't have a denial of services being rewarded, because if a provider is going to get paid for a positive outcome and that outcome requires a service, they'll deliver the service because then they'll get paid because the outcome is going to be there. If the service is not necessary to the outcome, then they're not going to do it. And that's appropriate. And that'll take care of some overutilization that we know exists in the current system. Vivian, take it away.
Yeah, I would agree with you with that. No system is perfect, but the problem with the fee-for-service system we have now, it's a license to print money. And so the most prominent value-based system is the Accountable Care Organization programs that are run by the Center for Medicare and Medicaid Services under Medicare. And they're not perfect. I understand that, but every single one of those ACO type reimbursement plans includes multiple scores of measures of quality that ACOs have to achieve in order to receive their reimbursement. So they're checking whether there's proper screening for diabetic patients. They're checking on whether smoking cessation programs have been implemented. They're checking on all sorts of things in terms of blood pressure, diabetes, and things like that. So it's not perfect, I agree, but I think it's better than fee-for-service. Okay, let me, you're getting lots of good questions here. So this question, thank you, Elena, for your insightful presentation. We both sit on a hospital district board. So this is from, I'll let you know, it's from Mara Musaitif.
She's in Travis County. Hi.
Okay. And would like your advice on how we can move the needle in bridging health. Allocate funding for health services, not just medical services, giving our funding stream is separate from our public health funding.
The streams may be separate, but they can be coordinated. And actually, you in Travis County have an advantage in that you don't own healthcare facilities. What you're doing is paying for services, and you have a lot more leeway in deciding what you value and what you pay for, because you're not feeding healthcare system infrastructure. And so I would invite you, and you also you have one health department and one hospital district. You could work together in Austin, Travis County to align the budgets. I understand they're separately budgeted, but that doesn't mean they couldn't be planned and implemented in tandem.
Okay, in addition to telehealth and provider expansions, which additional temporary COVID-19 changes should become permanent or should be a pathway to more upstream initiatives?
That's a good question, and I'm trying to think of which other ones are in place right now. I'll give you one. CMS is now paying for the cost of uninsured care in a more direct way. So that's one example. I'm trying to think off the top of my head of others that ought to be retained. I'll give you, there are a lot that have to do with administrative burdens, particularly in Medicaid and in food stamps. Right now, the rules require that the state not disenroll people from Medicaid as readily as they typically have been disenrolling people. There's no reason that those rules can't stay in place. Also, the process for signing people up for Medicaid and other benefits have been streamlined. Why wouldn't we do that all the time?
Yeah, definitely, I agree with you. Can you comment on smaller rural communities on the verge of losing or who may have already lost critical health infrastructure, or ideas on gathering resources to rebuild their capacity for providing care?
Yes, that is a great question. And Episcopal Health Foundation, as Lynette said, of course, covers many rural areas. When we started working on this issue, we ended up doing a lot of work with Dr. Nancy Dickey at Texas A&M University, who is an expert in rural health. And she talked about looking at the problem differently. Instead of saying, why are our rural hospitals closing? She turned the question on its head and said, how do we optimize rural healthcare services? And rather than trying to start from the perspective of you must save a hospital that's not in use and that the population doesn't really want to use and can't afford, is there another way to structure those services? And in fact, she's gotten so far along in this work that the federal government gave her about $5 million to start the National Center for Optimizing Rural Healthcare. And what she's trying to do is work with communities to look at what is it that you really need in this community. If you're in a community of 5,000 people, the answer is probably not a hospital if you're 30 miles from a real hospital. And I think she's making progress in helping people get their heads around having their needs met by something other than a hospital. We're so accustomed to thinking health hospital. And once you break that chain of connection in people's minds and you understand what it is people actually need in terms of healthcare delivery in their own communities, you have a really different conversation.
Elena, talk about how that first developed with our working relationship with her, how it started with really a fairly small seed and then has grown quite rapidly.
Yeah. I mean, she, we met her near the beginning of our existence because we were out meeting people, trying to learn the communities. We were based in Houston. All of my work previously had been in Houston or on national issues. And when we met with her, we told her that we had been receiving calls from hospitals in the rural area saying, oh, you're a new foundation. Thank God you're here. You're going to save our hospital. And we knew that we weren't going to do that because that's not what we were set up to do. But in having that conversation with her, she said, there's a different way to look at this. And we gave her a little bit of money. I want to say it was less than $100,000 to do a little bit of research into what was actually going on in these communities where hospitals had closed. And what she learned was they were closing often because the communities weren't supporting them. Communities were going elsewhere. They were going for hospital needs, which are not frequent needs, to bigger medical centers where there were more services and at least a perception of higher quality services. And so from that, she began exploring, so how do you talk to communities about that? And we got Robert Wood Johnson Foundation interested in the work. And they gave her a lot more money than we did, almost $1 $750,000 to deepen the work and to nationalize it. And then that was followed by the federal government's funding, so that our little investment, which over 5 years now has been less than, maybe it's $250,000, has yielded a national center. And I think she's helping those communities who are willing to have the conversation figure out how to get what they need and pay for it.
Oh, that's terrific. So another question, our nation is so politically polarized. What approach would you suggest to embark on getting coverage for all?
I don't know. I think we would first have to agree that it is in everyone's interest, regardless of whether you think healthcare is a right or a privilege, regardless of whether you think we should have a Bernie Sanders Medicare for all, where the government pays for every single thing that anybody might ever want, period, versus nobody pays for anything and you're on your own. If you can come to an understanding and agreement that we have to have a system that is rational in acknowledging that we all are here, we all are going to incur healthcare costs at some point in time. And if you can agree on that, then you might be able to have discussions about, so what is the appropriate role for government, for business, and for individuals to play in paying for those costs and in setting up systems to organize the delivery of that care. But first, you've got to get agreement that we ought to have a plan that deals with everyone, and we don't have that.
Right, but with this pandemic and 22 million people having lost their jobs, many of them having lost their health insurance because of that, maybe that'll be enough to start moving the debate and the discussion forward.
Right, it may be. I mean, we know that all the discussions around single payer or public option have those who have not embraced it, and I am one of those who have not embraced a single payer plan. It has been because so many people, half the people in this country, get their insurance through employers and they claim to like it. This may change their perception about how much security that system has given them.
Mm-hmm. Does the Episcopal Health Foundation have representatives who try to provide education and awareness to the Texas legislature?
We don't lobby. We have a research group, and we write and we publish and we research. We are available as experts, and we have spoken to legislators as well as to agency staff, but we don't do direct lobbying. We have a perspective. It is always research-based. It is also oriented in our commitment to the least among us. And so we're not lobbyists, but we have an opinion and we have a lot of data, and we are anxious to share it.
So just because many people have been asking the same question, they're asking whether a recording of this will be available afterwards. And the recording will be available on the Baker Institute website. You just look for this webinar under past events. That recording should be available and posted within the next hour or 2 hours. And someone also asked Elena about the slides. Will you make the slides available as well?
Yes,
okay.
I'll send the slides over.
We'll post those on the website as well. Okay, next question. What would you recommend for a focus? The myriad of elements feeding into a solution is far too broad for any one organization. Action elements?
For a focus on entire system redesign. So if you go back to the days of the Affordable Care Act, and you can love it or you can hate it, what it intended to do was bring more people, almost all people, but most people, into a system. What it didn't do was attack some of the other problems like costs as aggressively as people might have liked. But I think their goal was to get everybody in and then sort it out. I feel biased in that direction, because if you're going to reform a system, you need to have everybody in it sort of at the table at the same time. Otherwise, you're doing a piece of the system. And so I would still lean toward, despite all my health, not just healthcare, I would lean heavily toward bringing everyone into insurance. And then I would talk about, so that insurance you've got, what's it paying for? How's it paying for it? Is it paying for the right things?
Okay. How can prevention and community health be communicated to the public as being more effective? And are groups working on better ways to get this message communicated to lawmakers?
Um, for the latter, yes, I think lawmakers are becoming increasingly more aware. We did some polling earlier this year, public opinion polling on social determinants of health, not using that title, but asking people whether or not they had an understanding of the value and importance of social determinants in determining health outcomes. And we found that there was a pretty good understanding of the impact that these factors have on your health. I think the problem we have, and this is local, state, and federal government, is that we have siloed budgets and programming in a way that keeps us from looking holistically at what is it a person, a neighborhood, a community needs to be healthy. And so the healthcare system says, yes, we know people are really sick because they're in substandard housing and then they come into the hospital, but that's somebody else's problem. And the housing system is saying, yes, maybe our housing is making them sick, but somebody else has to pay for that. And we're starting to see an increasing reliance on programs that are multi-sectoral and that recognize that multiple sectors, multiple funding streams, multiple kinds of service delivery have to all be involved to lift up a community, because otherwise you fix one problem, the others remain. And we are in some early experimental work around a model called Accountable Communities for Health that look at different ways of bringing together all of these various sectors and then essentially trying to allocate both responsibility and benefit for looking at these multi-sectoral opportunities. And you can see that we actually have a project going in the Travis County area, which I hope Maram is not going to fall through, where we are looking at combining the city who's interested in homelessness, the county who's interested in criminal justice relief, and the healthcare system that is interested in not paying for services that aren't needed if you can prevent those, all of them working together on a program that will provide permanent supportive housing solutions to chronically homeless individuals, which will reduce over time their need for emergency room and inpatient services because they will get other kinds of health services. They will not be interacting with the criminal justice system because they will be in programs that are supporting their needs and keeping them out of trouble. And they will not be homeless because they will be housed in an environment that provides wraparound services that will help them. But this takes funding by multiple different organizations working together to produce a combined success, but each of them has a benefit from that success.
Elena, talk too about what we've done with Prosper Waco, because that's another example of a community who's looked more broadly at issues and how they might deal with the deeper problems within the community.
That's a great one. So Prosper Waco is a collaborative in Waco, Texas that predates us, and we discovered it and latched onto it because it has full community engagement and it has political and civic leadership as well as healthcare and the justice system and all of the other systems that are involved in lifting up a community. What we're trying out in that community is a way of solving the problem that Vivian, your kind of people call wrong pockets problem. Or free rider problems. We are working with an economist who is now at the Urban Institute, who is using an algorithm that was developed and won a Nobel Prize in the 1970s that uses an auction methodology with a trusted broker for allocating the costs and benefits of these various kinds of intervention that yield public goods. And what they're trying to do is say if a healthy population is a public good in the sense that schools benefit from healthy kids, workforce benefits from healthy workers, criminal justice benefits from people who do not end up in the justice system, how do you allocate what those costs are using this auction method? And we'll see if it works or not.
Okay, so we actually have many more questions than we're going to be able to answer, and I need to unfortunately pose my last question from a viewer, and it's a provocative one. Since physicians have no control over their patients' compliance with healthy activities such as diet, exercise, and smoking, how can the results-oriented provider compensation be practical?
Well, you can risk stratify for risk so that a provider is not punished for a non-compliant patient, but you can also incent the provider to do a lot more than they're currently incented to do to get compliance. And that's not just with medication, but when you're talking about diet and exercise, if your patient is not compliant because they just refuse, there's got to be a way to document that. If your patient is non-compliant because they work 2 jobs and live in a food desert and can't eat healthy food because they can only afford to drive through the McDonald's, there are ways for you to get them connected to programs that can help them with that. And if you are paid for helping them get better eating habits, then you will do that. And so if we can pay the providers for doing that, we can likewise hold them accountable when they fail to do it, and we can excuse them when they tried and couldn't do it.
Thank you. Well, I'm sorry we couldn't get to everybody's question, but I appreciate everyone for your very thoughtful questions, and I thank you very much to Lynette Diley and Elena Marks for a wonderful discussion. You've informed us today on so many things related to improving health and working upstream and how it relates to COVID-19. And we wish you all the best in your work in the future. And again, everyone can access the, if you want to tell other friends about this webinar, they can access it off of the Baker Institute website. It should be available in an hour or two. And we appreciate your interest and support. Thank you.
Thanks.
Thank you.